Bismillah ar-Rahman ar-Rahim. It's a great pleasure for me to be in this session with these prestigious speakers, and I've been asked to finish in 5 instead of 10 minutes. What's a little bit helpful is that the previous speakers have covered a lot of what I wanted to say, but these 5 or 8 minutes, I'm going to just give the essence or the challenge that we are facing, whether in our clinical practice or in research, because it's completely different from heart failure in the patients on top of a structurally normal heart. So the challenges start from even the definition and the diagnosis. The imaging is completely different. The evaluation of the ventricles, especially the ventricular function and so on, is not the same as the patients who have heart failure on top of a structurally normal heart. So the challenges are starting from the point where you suspect and then diagnose and then image and then treat. Even the application of guideline-directed medical therapy is a little bit problematic here, but the guidelines are more and more helpful for us. So the ratio of the patients and the survival to adulthood has increased, and of course, the mortality from heart failure is one of the main causes of mortality in these patients. So heart failure is one of the most important long-term complications and causes of mortality in patients with congenital heart disease. And we have this problem in many countries, but especially in Egypt, the patients being lost to follow-up, and this bridge is always missing. So the guidelines, even the most new guidelines in December 2025, the American Heart Association have emphasized the importance of the patient-centered transition and transfer of care policies between the hospitals. So no consensus of definition of heart failure because the patient has never had a structurally normal myocardium. Since birth, there is a dysfunction and there is a problem in the structure also. So when is this going to be translated into heart failure and when to spot it and start treating early? Actually, the definitions are very variable from author to author, but in essence, all adult congenital heart disease patients have some form of heart failure. So some predictors are helpful, especially the complexity of the lesion. When you see the patient have a worsening NYHA class or worsening BNP levels. Some also helpful data, but not as helpful, the systemic ventricular ejection fraction, MVO2, and so on. So the complexity of the lesion, and you have always been more pessimistic about the patients with complex congenital heart disease, but when they develop heart failure, it's worse. So the course is, even with the same follow-up and same treatment, always worse, and the events are more, the hospitalization and more. You can divide it into the patients in whom have the ventricles right, as Dr. Ghada said. These patients are more close to the guidelines of the non-congenital heart disease patients because the ventricles suffer from volume overload or pressure overload, and the right ventricle is facing the right artery. So more or less, it's similar, but not very similar. But the problem, the challenge is in the other patients in whom there is the systemic ventricle is the right ventricle, like the congenitally corrected TGA, or the patients in general who have a subpulmonic failing right ventricle, like tetralogy of Fallot. These are the most common patients we see, and the other patients with Fontan are a growing population now, but still the main population we see are these two. You always have the problem of electric activity, arrhythmias, the risk of developing atrial fibrillation, sudden cardiac death, and so on. Of course, the systemic right ventricle has been covered by Dr. Ghada, but the medical therapy, the CRT, and everything is still questionable and need more long-term data to decide what will be useful on the long run and decrease mortality. The Fontan patient is a big problem, and every one of us following adults with congenital heart disease have this sort of patient coming hospitalized, compensated, going out, and then decompensated again, and so on. Of course, in all heart failure in adult congenital heart disease, you need to be cautious in medical treatment. Not all guideline-directed medical treatment is suitable. When you see a patient with congenitally corrected TGA, be cautious before beta blocker for development of heart block. When you see a patient with Fontan and protein-losing enteropathy, always hypotensive, be cautious in vasodilators, and so on. So tailor the guideline-directed medical treatment for each patient until the guidelines are more clear. For example, routine diuretic therapy, and sometimes we have to give aggressive diuretic therapy for the congested patient with Fontan, should be used with caution. This is one of the patients with Fontan. She always comes and readmitted and readmitted, and here she has a big thrombus inside, and the main vent inside the Fontan connection, and the main ventricle is failing, and this patient has now no option except transplantation. This is one of my patients, also very frustrating. All of this, you keep zooming and zooming on the image, all of this is the right heart, the right atrium and the right ventricle with poor function, as you see. And the problem, as we don't have up till now a transplantation program in Egypt, but the problem is also that the guidelines for mechanical circulatory support and transplantation are not very clear in these guidelines, but the number of patients with ventricular assist devices as a bridge of transplantation is increasing, and the outcomes are increasing. Some of the positive or bright sides, the 3D printing, the 3D echo and the MRI, and then 3D printing have made the ventricular assist devices more suitable and more tailored for the anatomy of each of these patients. And the 2025 guidelines of the American Heart Association for adult congenital heart disease have all new sections in heart failure treatment and in ventricular assist devices and transplantation. All of you working in this domain are advised to review it. The also positive point, the higher 10-year survival in patients with transplantation for adult congenital heart failure. So they have higher 10-year survival, although when listed for transplantation, many of them die before transplantation. But if go to transplantation, they have a higher 10-year survival. So the recommendations are very clear here. Advanced therapies. This is the 2025 December guidelines. Advanced mechanical circulatory support, ventricular assist device, and transplantation. Of course, the leadless pacemaker are a great help because of the complex anatomy. They are helpful in the usual patients and multi-organ transplantation. Heart lung, heart liver, heart kidney transplantation is now developing and is in the guidelines. Thank you.